Both Montana and Wyoming are very rural, and our patients have to travel a great distance in order to seek tertiary care. There's nowhere that continuity of care is more important than a patient that's been transported 250 miles to a specialty care provider and then needs to transition back to their primary care provider. Sometimes the distance can create additional challenges in communication, particularly for our medically complex patients. My name is Ginny Mole, and I'm a family physician, and I'm serving as Chief of Regional Medicine. One of the most common causes of readmission are a lack of clarity in what was happening with the patient and what was the expectations. In particular, if someone is hospitalized, that's a significant event in their family, and they think that there's something wrong with their care if when they get back to their primary care provider, they don't know what happened to them.
My name is Elizabeth Ciemins. I'm a research scientist and the director of the Center for Clinical Translational Research at Billings Clinic. I'm the principal investigator on this AHRQ-funded study to improve care transitions through enhanced provider and patient communication. We conducted a 4-year prospective controlled intervention study among about 1,200 rural patients. We've targeted patients who were medically complex, and they were discharged from our hospital to home. These are patients who live in our 121,000 square mile service area that covers 40 counties in Montana, the Dakotas, and Wyoming. The goal of our study was to improve the care transitions for patients in our rural communities. In particular, we were looking at medically complex patients, patients who have 2 or more chronic conditions, who are at higher risk of readmissions and adverse outcomes. We know from the literature that patients who get follow-up after their hospitalization are less likely to be readmitted to the hospital. We're constantly trying to improve our care here at Billings Clinic, and that includes care transitions. We have an electronic health record. What we did notice is that in all of our different departments in the hospital, they were using different processes to discharge patients. So to address these challenges, we designed a health information technology supported communication system that included 2 pieces. The DPAR process is made up of the standardized discharge checklist as well as the primary care provider automated notification system. The discharge checklist standardizes the process for discharging a patient so that our nurses discharging the patients can go through each step of the process, make sure that they don't forget anything, and it's put in a logical way of how they would conduct the discharge. The second piece of the intervention included a primary care provider notification that was automatically faxed at time of discharge to the receiving provider in the rural community. This notification included information about the patient's admission and discharge dates, why they were in the hospital, what medications they were on, what follow-up appointments had been scheduled, and what major diagnostic tests were conducted during their hospitalization. The intent of the PCP notification was to alert providers that their patients had been in the hospital and to get them to go into the EHR through a provider portal to get full information on the patient's hospitalization. Having that information in the rural health centers allowed those providers to proactively contact patients and make sure that they got the follow-up care that they needed to prevent emergent care visits and rehospitalizations.
My name is Curtis Farron, and my role here at Billings Clinic is an admission discharge transfer nurse. During the discharge process, when I'm in front of patients and their families, they're going to receive specific discharge instructions, and they're going to receive what tests or lab work that they need to follow up with. So it creates a bigger trust factor for patients because they see that everything is organized and ready to go. We have to remember when we discharge people from our hospital that we're not done. That's what follow-up phone calls are very helpful with, because we're still working with them even though they're outside the hospital. And if they're successful at home, that's likely going to mean they're not going to have to come back.
We found patients were fully prepared and empowered to take care of themselves following their hospitalization. These improvements that we realized through this project are so important because patients who are more informed, know why they're taking their medications, receive follow-up care, are less likely to be readmitted, receive any type of emergent care following hospitalizations or have any adverse health outcomes. Our model provides an example of how health IT can be leveraged to improve the communication between inpatient and outpatient providers, patients, and families.
Health IT has transformed the way that I'm able to care for patients, and it's transforming the way that we as a system are able to care for patients across our entire region. And we're so excited as what the future is going to bring.